We have a nurse, Lauren Galata.
Yes.
From Kansas City. Lauren can tell you some of her case history, and I don't think you've ever been to a chiropractor before, have you?
No, okay. I have not. I'm a nurse. I work nights, and I have a lot of neck pain. I have headaches every day. They start in the back of my neck and just radiate up, and then I have pain in my back that radiates all the way down to my lower back, and my legs hurt from it. I do a lot of heavy lifting, and I've been in a few car wrecks and had, I think, a few MRIs just saying that it's just whiplash. So I haven't really done anything for it.
Okay, Lauren, let's go back a couple of days ago. Let's just tell them that you were a new patient a couple of days ago, a bit nervous and apprehensive, and she had a headache constantly, like every day, all the time. And did an evaluation, and you got a treatment a couple of days ago. Now, how have your headaches been?
I haven't had any headaches, which is awesome.
This is a young lady, 23, a nurse, very bright, going for her doctor's degree, headache every day, whiplash, torque spine, scoliosis, doesn't know what to do. How many nurses, people are out there right now that have had your automobile accident, your whiplash, or a fall, or a twist, or an athletic injury, or whatever, that every day you hurt. And you just assume, well, I'll just learn to live with it because you prefer not to take medication?
No, I don't take medication.
But you're in the medication business?
Yes.
Okay. You've probably seen enough where you prefer not to take medication.
Yes, I don't want to live off of medication.
So for the people who don't want to live on medication, that heals you from the outside in. The medication then kills your in. Although it helps your symptoms or kills the bacteria, it kills your in, so your in can't heal you from in out. Not that it's not necessary. It is. It's not if it's necessary, it's how you use it. And as you know, if you read articles, we're using medication too much, way too much. It becomes random and easy and simple in prescriptions. Not that she might not need it someday, but 23 years old, why would we turn into a drug addict? Why now? Why get her into the habit of taking medication? Or kids younger than her, you parents that don't know any other way, and you take your kids to the doctor and they start taking medication. Excuse the phone ringing. Okay, well, that's just a way and a habit of life that starts and continues on. So maybe now that Lauren's here, that we can change that pattern. And she was not necessarily a believer, like this. The patient you saw before was his first time. Okay, and you'll see that video. We'd have liked to seen him get 100% well, but at 61 years old, the cartilage in his SI joint just tore up. But he felt a lot better. Okay. So with Lauren, I'm going to go over her spine and tell you what we did before. And also, I talked to Lauren about, she asked me some questions. And when I work on her, it'll remind me of some of the questions you asked me, and we'll go over that. It's kind of interesting. Face down, please. Ah, good, it's still there. I was going to treat Lauren, so thank her because she didn't get any treatments other than 2 days ago, even though she was supposed to. I asked her to wait till today, that maybe she'd go out of alignment again. See, what she's had for years is a pattern. So she has developed plastic deformation, where her body accepted the pattern, even though her body's talking to her with pain. Lauren, don't do that. Lauren, help me. Lauren, do that. Lauren, I'm hurting. Lauren, fix me. But Lauren says, oh, I don't know how. I'm doing the best thing. I don't know how. So all these patterns develop, and unless she slipped and fell on the ice or accidentally got popped in the back or whatever, then her misalignment stays there. Her structural imbalance stays, causing functional problems. Understand that. Structure causes function. Function can cause structure. But for the most part, you don't fix the structure, why mess with the function? Why would you go exercise, do all these exercises and stretching and everything for your muscles if the muscles are shortened on one side and elongated on the other side? What good are you doing except developing a bad golf swing or developing a bad baseball swing? you're getting bad and making it worse. Structure, 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 structure. Why so important? Gravity, 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 gravity. Gravity pulls your structure front, back, sideways, all the way, all the time, constantly, anytime you're up on your feet or sitting, even laying down. Fix the structure. I love you functional people. I love the the physical therapists who do exercise. I love the exercise trainers. I love all you people and trainers teaching exercise. But did you ever look at structure? You ever lay somebody down and see that the right leg was 3 inches shorter, but go ahead and keep exercising? You're going to hurt that person. You're going to hurt that person. You, the person, you're never going to get well that way. Okay, now let's check her. These are all my opinions, so. All right. Well, certainly not like it was the other day. You're no fun, Lauren. You're better. All right. So we have a right short leg. Can you see this, Jerry? It was like 2 inches the other day. This leg was shorter. Now, as you can see, Lauren, you put your right hand here for me like we did the other day, please. Here on your hip and your left hand. All right. Now look at her elbows. High, low. You feel the low here, and do you feel the high here? Very much so. This is important. You have to see this, where her arm's sloping down. Okay? Her arm is sloping down. When you're high here, you have to reach back further to get to it. So the elbow's distorted. Okay? And the patient can feel, wow. All right? Now arms down. And you can almost see it, and excuse me, she's shallower here and fuller here. And like you young people, old people, any person, you want to walk around with one flat butt and one protruding butt? I don't. I would like my butts to be symmetrical, and even whether they're good or not, I don't want them to be crooked, right? So some people feel even stronger about their butts being symmetrical and even. Some people won't even wear a bathing suit because of that, or look in the mirror, they're all crooked. Mom, Dad, look, why am I so crooked? I don't want to put that bathing suit on. All right, so we have low here, high here. Here's the ischium bone, here. Here's the ischium bone, here. That's an inch. High ischium, low ischium. Sacrum, here, sacrum, here. That's about probably a ½ inch. So what do we have? Pelvis twisted anterior on the right. Pelvis shifted up on the left. Sacrum deviating and up on the left, causing tremendous amount of problems here. Is that painful, honey?
Yes.
Yes. Stop it. I can tell it's tender because it's giving. It's a little mushy around right at L5. Okay, how about 4?
Yeah.
Yeah. And 3?
Yes.
2?
Yeah.
Not much though, huh?
No.
See, it gets hard at 2. The palpation is not as mushy. The inflammation, the bogginess around L3 is 2 is not bad. 3, 4, 5 bad. Okay. So let's come down here. Let's do different than we did with Keith. Let's start at the feet. Left Achilles tendon. Okay, flat. See, it's flat. Flat. Right Achilles tendon, bulging out to here. Here's the distal end of your gastrocnemius. I can see this here. I can't see it over here. Correct? And look at it here. Sticks right out. Is that tender?
Yes.
A lot?
Yes.
You didn't say anything much. How about this one?
A little bit.
A little bit, right? Let's go up into your gastroc. How about here?
Yeah.
You don't like that?
No.
Okay, you athletes. Wonder if you're walking around with this, and we've had 1 million hits on these YouTubes, and I've probably had 500 questions about Achilles tendon. All right, your Achilles tendon connects to your calcaneus. Calcaneus connects to your navicular. Navicular connects to these other bones, especially your first toe, your digit, okay? It's all got to fire right. So if your Achilles tendon is bulging out, tight, and connected to your gastrocnemius muscle, your chance of tearing the muscle fiber here is significant. Calcaneus, navicular, first toe. They're all connected. Thank you. You're a great help, man. Yeah. So let's fix that first. More importantly, I've just converted a nurse to believe in chiropractic. If every chiropractor did that once a day, we could all form a coalition and take over the world. The healthcare world. All right. Let's get the navicular bone. All right. Now let's prop down the calcaneus. Evert the foot. Tap it in. Evert the foot. Now, my glove. Wow. I mean, I do this 200 times a week, thousands of times. My hands were terrible. Waking up at night, not being able to open my finger, trigger finger is bruised, carpal tunnel. Since I got this, I just tap it like that. Man, it's wonderful for my hands. It's wonderful for my hands. It's like $50, you get 2 of them. They last you 6 months, get 2 more. If you adjust a lot. If you start doing this technique, you will start adjusting a lot because everybody's going to want to see you. So let's go back. Okay, now, this is flatter here. Can you see that? And you feel your Achilles tendons looser here?
Yes.
Now let's squeeze it.
Doesn't hurt.
Doesn't hurt. Does it hurt little or doesn't hurt?
It doesn't hurt as much as it did.
Much less. So I took the stress off the Achilles tendon. Okay, now let's check the first toe digit. Stuck. First digit here. You fix it, you hold it here at the base. Okay, look at this. That's loose. So let's hold this one. You feel that, Lauren? It's stuck.
Yeah.
Doesn't want to move. Flexus hallucis limitus. So we adjust it. And some people, it hurts sometimes. But you don't scrunch it. You're pulling up. Don't scrunch it. It's this way. It's out and up. Okay? So now, well, isn't that nice? What's that called? The windlass effect. You're not going to run effectively and coordinatedly and normally unless this toe, the windlass effect, triggers the rest of the muscles and the calcaneus and the arch and everything, and it sets your foot in motion and you have a normal gait. You got to have the windlass effect. Ask Dr. Kevin Heron that. He'll tell you it's true. Okay, now let's check the leg lengths to see if that changed anything. What did we have before? A short right leg?
Yes.
Well, now we have a short left leg. Can you see that, Jerry? So before, this leg was shorter. Now, after adjusting the foot, this leg is longer. Well, why? By adjusting the navicular and adjusting the calcaneus, I brought the calcaneus down and forward, which gives you a length increase, leg length. So if causing your scoliosis is a leg length deficiency, and they say you need to be in a brace, or we're going to have to watch your scoliosis, or we're going to have to do these exercises, don't you think it's worth even having someone check the calcaneus, the navicular, the first toe to see if the foot's in alignment, to see if this actually isn't shorter than it should be because the calcaneus is up, causing a short leg on that side, which then causes a deviation in the spinal curvature? Don't you think you should at least ask? You should at least ask. Don't you think your doctor, before they do a new hip or a new knee, would first see if you have a leg deficiency and that's causing a twisted pelvis and a hip socket to rotate? You people getting new hips? Why? In God's creation, would you want to put a new good hip in a bad socket? Why? Has your surgeon ever mentioned it to you? Hey, you know what? You better go see the chiropractor who does a drop maneuver, who fixes your sacrum and fixes your tailbone, and actually causes the hemipelvis on that hip side to rotate back. When I'm doing this, I'm rotating the hip socket. Rotating the hip socket, changing how the head of the femur sits into the socket. Why you think the hip went bad and the other hip is good? You're getting uneven wear and tear and you're wearing out your hip. You think you would wear it out if you were properly balanced and everything's sitting beautifully and it's really a nice motion? Well, maybe, but if we're a whole lot longer, it lasts a lot longer. God made it to last. Why would one hip be bad and the other be good? Yeah. There's a lot of reasons about hips. Let's just consider this one. And how many people walk around with a short leg, with a rotated socket, with a hip out of alignment, and they need a new hip? Can you prevent the new hip? Or can you prevent having to have a new hip by keeping your pelvis corrected? Absolutely. Can you prevent uneven wear on your knee by balancing out your pelvis, straightening out your extremities, so now instead of your knee being bone to bone like this, it's in a nice groove. Can you get that groove, Jerry? It's in a groove. But when the tibia, so let's say this is the tibia, rotates out because your foot's out of alignment and your back's out of alignment, it goes bone to bone. You got high point hitting high point. You got the distal head of the femur and the proximal head of the tibia banging into each other. You don't initially feel it because you're young, strong, athletically. Sooner or later you wear out your knee. By the way, you're 42, you need a new knee. Well, that's insane. Obviously, there was something that precipitated it and was preliminary before your knee went bad, before your hip went bad. People, you have to check the alignment. I had a new hip in March. Okay, I had to. I was born with a hip disease. My hip went bad finally. It was only supposed to last 45 years, lasted 66, so hallelujah, it was wonderful. But I had my adjustments. I had my pelvis corrected half a dozen times, 3 times a week for 2 weeks before I went and had my hip surgery. So when I went in to have my hip surgery, my pelvis is even. So when they put the new hip into the good socket, I got a good socket and good hip and good alignment. You put the good metal hip into a bad bony socket, what's going to happen? Your outcome is not going to be as good. When you put a new knee, chop off these bones and slam that new knee and push those rods down to the femur and, you know, and make that new knee. Do you want your tibia to be rotated? Do you want your knee to be sitting crooked? So there's your new knee, and you wonder why you don't come out of rehab good. You wonder why it hurts all the time. Sometimes it can't be prevented. But if you want to increase your outcome, make sure you're lined up before anybody chops you up, puts a new hip or a new knee. My opinion. My opinion. Okay? I'll debate anybody about it, orthopedic surgeon, whatever. Let's talk. Let's debate. Let's do a YouTube video. Okay? I'll show you where I'll change this socket with a sacral adjustment and a drop. Okay? Low here, high here. Bend this leg. Okay? Let's roll the hip out on this side. Any pain?
A little bit.
Okay, let's roll it in. Kind of tight there, isn't it?
Yes.
Okay, 45? 60? Just guess. Okay? Give me this one. Let's roll it in. 80? Yes, nurse?
Yes.
Okay. Okay. Well, I would prefer to have her left hip, not her right hip. Okay, so the range of motion at the hip joints are asymmetrical. They're different. They're not functioning like they're supposed to, right and left, symmetrically with gravity. So gravity's pulling her away. Let's do something. Here's the test. If this works, you'll see it on YouTube. If it doesn't work, you'll never see it. All right? And she'll be so sad. All right, okay, let's get the pelvis. Heave my pelvis down, so I'm correcting the whole sacrum. Okay? And I know what you guys are saying. Bring Lauren back again. Some of you people on YouTube. Okay? Now let's get the tailbone fixed. Come on. Okay? And let's get the ischium fixed. All right? Now put your right hand here. Left hand here. What do you feel?
Feels even.
It's what?
Even.
Even. See her elbows? No more sloping down. She's even. Okay? Thank you. Now let's check the leg lengths. We might have a 1/4 inch on the right. You see that, everybody? Okay? Now, almost, she needs like 3 or 4 more adjustments, not 300. 3 or 4. Okay? I'd rather see people 10 times, get them well very effectively. They send me 10 patients. I each see 10 times, charge more, make everybody happy, and people have to do my best to be here to turn people down because they want to get in. Rather than signing contracts, saying they have to come 3 times a week for 50 weeks, taking x-rays all the time. You know, that's not my deal. if you, chiropractor, if that's your deal, and you feel honestly, spiritually inside yourself, that's the right thing you can do, you're doing, and it's the most you can do. The most you can do to get this human being well as fast and most efficient as possible, then you're on the right track. But if you feel just a little slummy sometimes and not right, that you're seeing this patient over and over and over, doctor, when am I going to get well? It only lasts for a day. You'll be all right. Take your time. It takes time. Are you doing all you can do? If you're not adjusting the feet, automatically, you're not. Okay? Okay. Bend your knee. This is the bad hip. Okay? Bring it out. Well. 80 to 90 degrees. That was what, 45? 50?
Yeah.
Oh, give it to me again. Bring it this way. It's 80 degrees. Okay, no trickery. Believe what you want. Okay, believe what you want. See, Mr. Duke, I got you. Okay, believe what you want. Okay, but by the adjustment we just did, I just doubled the range of motion of the right hip. If she was getting a new hip, don't you think she would get a better new hip now that I balanced everything out and it's sitting in its right socket? So when they come in to duplicate the hip, they put it in a normal aligned pelvis. So now her hip is fixed. For now. Will it last forever? No. She needs to get to a stable point. Then she's going to be perfect for a while. Then every month I see people to maintain them, not to fix them. You get them to a point of where you want them with gravitational pattern adjusting. Then you see them monthly to keep them that way. If you keep treating them over and over and over and you're not there yet, you better look for something else, man. And ladies and doctors, let's go upper spine. Movement palpation. Oh, let's go L5. Still tender?
Yeah.
Yeah. L4?
Yes.
It's still tender in the low back, so let's do a nice little side posture adjustment to just mobilize L4, 5, and 3, 4, and 5. Lay on your side, face me. That's a girl. Bend this right here. Come forward. Come forward. I'm not, no. Here, like this. As you can see, lay on your side now. Okay, straighten the bottom leg, drop this off. That's a girl. All right, I got you. Okay, let's do the other side. Straighten the bottom leg. Just let it drop off. I use my elbow to adjust. Nice like that, on your back. Hi, Lauren, how you doing?
Good.
Let's use some dorsiflexion now to check the dorsiflexion in the ankles. I feel tightness on this side. And she kind of turns in a little bit more here. She supinates, right? And this has been kind of dysfunctional side anyway, so I go, and we already adjusted the toe, the calcaneus, and the navicular, so I get this talus because it's rolled in. I get the talus and clunk, nice little clunk, right? Mm-hmm. And it clunked right in place. If you do it the right angle and move it where it's supposed to move, you don't have to slam it. Unless you're dealing with a 300-pound football player, and you do, because they're so jammed up. So help that little supination better, but again, she has plastic deformation, it's going to take time. Bend your knee. Okay, internal rotation, external, 90 degrees. But look here, that stops there, doesn't it? 30. Okay, 30 degrees. So let's do I touch your pubic bone, right? So females on the table, or even males, I have to touch your pubic bone. Okay, and you just tap it. Come on, like so. Tapping the pubic bone. The pubic bone is connected to the hemipelvis, connected to the hip socket. So what I found out after an accidental discovery 15 years ago, if I adjust the pubic bone, it moves the hip socket. It moves the hip socket, so the head of the femur changes its position. Pubic bone, hip socket, okay, head of the femur locked. Pubic bone, head of the femur loosens up. Let's see. Okay. That's much better, huh? Well, it went from like 40 degrees to 80. Let's look at. I won't try so hard. Oh, still. Not trickery, reality. No matter what some of you think. Hello, Raheem. Okay, now external rotation, internal rotation. She's actually got locked on both sides. So let's do this side. I need to touch you right here, okay? And then we free up the hips. Good. This girl's been suffering for a long time. All right, scoot down this way just a little. As I was moving palpation of the vertebra, at about T11, it's just stopped moving. She's fixated. So I'm going to do anteriority adjustment. Now, doing the anteriority adjustment with this pad here, wow, saves my hand. You can do a lot with an anteriority adjustment. The patient supine, arms on their chest, lift up your head. I put my hand under their neck, control with their shoulder, bring it up and down. So just relax now, I say, and I just adjust them. And you'll hear nice manipulation, mobilization, nothing specific, just an opening up in the thoracic spine. Felt good, didn't it?
Yeah.
She's being paid to say that, so you know. Okay, let's come up here. She had headaches every day. Okay, so I palpate the mastoid bone. Look down to see if there's a temporal bulge, right or left side. Usually I find a temporal bulge on the left side. Excuse me a second. Which means chronic pain, stress, anger, fear. I'm sad. I'm going to because you have a left temporal bulge. Not so bad now today. So we go to the mastoid. Mastoid on the right, mastoid on the left. The mastoid is part of the skull. The skull sits on C1 pillars. Okay? And it slides. They slide like this. So if I check the mastoid on the right and the mastoid on the left, I have the right mastoid bone, okay, back and up. Okay, so the left mastoid is jamming into C1. How can you adjust C1 if it's being jammed and locked in by the mastoid of the occiput? You can, but you're going to hurt somebody. Dr. Bill showed me this. Okay, mastoid is up and back. And this is about 30 degrees. Okay, so I'm going to turn her head 30 degrees, about there. So it's the same, the line of drive is the opposite way like a mirror. And then I'm going to get the occiput and slide it, the lateral occiput, on the pillars of C1. Right, Dr. Bill?
Right.
All right. Then I come back and check the mastoid, okay? Perfectly even. Now let's slide off the mastoids. Ooh. That's not good there, is it? First cervical. And that's where her earring just fall out. Okay, I'll get it though. Mario will buy you new ones. All right. So the first cervical on the left, awful. This is where she's got damage. This is where more than 10 visits for this young girl, so she doesn't have miserable problems by the time she's older, 40s or 50. It's got to be done because this pattern is set up, and it only lasted 2 days since the last time I adjusted her, and it came back quite a bit. She needs a series of adjustments and probably some x-rays. Everybody's different. You don't do everything routine with everybody. That's wrong. Everybody's different. You're different than me. I'm different than you. Don't treat everybody the same. But let's go over to the first cervical. Turn your head right. Smile. Come on. Smile. Come on. No. Thank you. Wow. Nice, huh? I made your toes curl up. Your toes curl. Is it toes curl or is it toes curl? You know, either one. Yeah. So now we go into C1. Pretty nice, huh? Mm-hmm. Yeah. And your head feels clear, right? Lauren got this the other day, and she's bouncing around the office and going like, talking like what? Her whole life, I mean, she just woke right up. It was so nice to take that pressure off the first cervical vertebra and the brainstem. And she's smart anyway. Now she's a lot smarter. Okay, come on up for me. Swing your feet this way. I'm sorry if I messed your hair for the video. You know.
Okay.
All right, let's check the sternoclavicular joints. High on the left, low on the right. First rib, real tender. So we got a little bit of a thoracic outlet. Just FYI, this arm ever bother you?
Sometimes.
Not a big deal though, right?
No.
Does it ever feel weak or anything? No?
Sometimes.
Sometimes. This arm, no?
Not as much.
Often, once in a while you feel this, right?
Yeah.
So she has high left sternoclavicular joint. She has a very palpable, oh yeah, she has very palpable first rib. Scoliosis, where she's not getting really a reactive thing specifically locally. This is a result of all this other stuff that's happening in her spine. That makes more sense, doesn't it?
Yeah.
Yeah. So her second rib is nasty right here. Tender?
Yeah.
Okay, move to the left. In the middle of the table, right there. So we're going to do the second rib tap. Bingo. So now when I come to the second rib, oh, nice and bouncy. Remember, first 4 ribs bucket handle. They're supposed to move up and down, up and down. They're not supposed to be hard and fixated. So let's come here, sternoclavicular joint. Very nice. First rib, still there on your back. Face up. Scoot down a little. So first rib. You do the table. Now we find the first rib here, just above the clavicle. Okay, I elevate her arm. Okay, elevate it, and then just tap the first rib in. Boom. And you know, another thing, chiropractors, remember, be careful what you do with your head. When you're around as long as I am, you stop putting your head this way so it bounces every time you do an adjustment and whiplash yourself. You get a deceleration whiplash 1,000,000 times. So I try to keep my head straight. I've learned the hard way. Okay, so that was the first rib. Let's go check it again. Oh man, I'll be darned, it worked. I'll be darned. How did that happen? Just on palpation, I feel a little something on the low right side about C7. So go this way, relax, and we'll just get that one. That was an innate thing. You know chiropractors, innate? You know patients with innate, I-N-N-A-T-E? Innate. It's an internal spiritual energy that you feel. And don't laugh. Oh, you realist and you scientist. There's something about healing where you do it long enough and you feel their inner self, and it tells you. You have to have a gut feeling. You have to have an intuitive feeling. So if you patients are looking for more of an intuitive healer, look for someone who has intuition. In your doctor, you have to look that in your doctor. A truth intuition. HIT. Honor, integrity, and truth. That's a big hit. Come on up. Swing your feet this way. That's nice. Well, that's the best I can do. Thank you, Lauren.
Thank you.
You're welcome.